So as Maurice mentioned, I come from India. It's a country with some spectacular natural beauty, a culture of over 3,000 years, some very, very friendly people. And for some of you who haven't visited this, I'd be really happy you pay us a visit someday during your lifetime. Where I come from is Mumbai. Mumbai is on the west coast of India. That's where Mumbai is situated. And these are the few statistics of our country and my city where I am born, brought up, and continue to work. So India is about 1.2 billion, as you can see, many mouths to feed. Mumbai itself is around 20 million, at least at the time when I left home, took the flight, we were about 20 million. I had a few to those by the time I reach home. And potentially that's the number of maxillary sinuses that we have to fill. So why I have put these two dramatically different photographs over here is just so that you understand the dynamics and the way, the kind of population that we are dealing with in our country. So this is the city of Mumbai, and the photograph here on the left is downtown Mumbai. And what you see over here is the most expensive residence in the world. Believe it or not, this is a 65-storied house which houses just a family of just one family of 5 people. Okay, this is in downtown Mumbai, the most expensive residence. So it's 65-storied where just 5 people are living. And to the on the other side, not that far off, just as the crow flies, maybe about 3 miles away, is the largest slum in Asia, where in about 100 square feet you might have 7 or 8 people living over there. And what I'm really proud about it is, in spite of this kind of a disparity, there is a lot of peace and harmony in our country. And those who visit our country someday will sense this kind of a harmony. So in this mad place called Mumbai, I have my little oasis here. That's my workplace where I spend all my time professionally. And apart from that, some of my time that I devote towards teaching. What I plan to speak today is going to be the various crestal approaches to sinus elevation. I'll talk a little bit about biomaterials. And I will talk a little bit about the paradigm shift in sinus elevations and ridge management, something that has really changed the way we are doing these procedures in the last couple of years. So what really are our challenges when it comes to the posterior maxilla? These two images again over here. You have the first image over here where you have pneumatization of the maxillary sinus, which limits the amount of bone that we have for implant placement. And the other image over there where there has been a vertical bone loss, perhaps because of previous periodontal disease or maybe some traumatic extractions. Now, both these situations would require some amount of sinus elevation and grafting, and we'll look at some of the options that are open to us these days. The bone density, we are all very familiar with this classification, and we know that in the posterior maxilla, we are just dealing with these two categories of bone. So we are really looking at bone which is a lot softer, lot porous, a bone that is extremely challenging for us to get our implants placed effectively and have good stability and high insertion torque values with high ISQ values on the day of implant placement. Let's jump on to the sinus floor elevation procedures, and traditionally this is how we have been categorizing our cases, or rather choosing our treatment options, all based on the amount of residual alveolar bone that exists. And most of us would agree that somewhere between 1 to 5 millimeters of available bone would be cases which would typically qualify for a direct sinus lift or a lateral window approach. Between 4 to 7 is again a zone where most of us would prefer to move on from a lateral approach to a more minimally invasive approach, which is the crestal sinus lift. And these days, with more and more data coming in favor of short implants, I think these numbers, when you're looking at 7, 8, and 9 millimeters of available bone below the maxillary sinus, we're perhaps not even looking at doing any kind of of an intervention or grafting into the sinus, and we are quite happy placing just short implants there. So let's start off with this graph, and let's talk a little bit now about the grafting materials. Now, a lot of clinicians across the world have tried out various grafting materials, and what is really heartening is most would agree over here that the sinus is one of the most forgiving area when it comes to choosing a grafting materials. So most of the grafting materials that have been tried over the years, any kind of bone substitutes, be it allografts, alloplasts, or xenografts, have all worked very well, either standalone or in combination with some autogenous bone. And what is also interesting to note is that pure autogenous bone inside the maxillary sinus has some of the poorest track record of implant survival. So if you look at this, some of these studies over here, it's pretty obvious that using a composite material, something mixed with autogenous, or even something standalone, any bone substitute material, could be an allograft, alloplast, or a xenograft, work extremely well in the sinus. As the years have rolled by, we've seen various other approaches. PRF again has been used, some of these blood derivatives effectively in the sinus without addition of any other bone graft material. And there is evidence increasing in favor of trying this kind of an approach. The only difficulty is the technical difficulty, especially if you are using a crestal approach and trying to insert PRF through a very small tiny opening. Technically becomes a very difficult procedure to accomplish. There is also room for just placing an implant without a graft, just tenting the sinus lining, just placing the implant over there in the available bone, and in the end eventually landing up in a situation where you will land up having bone around the apical part of this implant. Again, there is evidence in favor of this technique. My only reservation here is that it's very difficult for us to radiographically evaluate the success of a treatment like this. We only know whether this treatment is successful maybe about 9 months or 10 months down the line, when you start seeing some amount of bone formation over there. But on the day you place the implant, and maybe a few months after that, you are just looking at an implant on a radiograph which just seems to be sticking into the sinus with no bone surrounding. But yes, for those of you who do not believe in using graft materials, just tenting the membrane and placing an implant there also has some evidence in literature. Like I said, the 1 to 5 millimeter spectrum of cases with available bone, we've been doing lateral window sinus elevations or the direct sinus lifts. The only issue with these have worked extremely well for the last 3 to 4 decades, but the only issue with this has been the increased morbidity, and because of that, when it comes to treating patients, we do find that a lot of patients find a procedure like this a little intimidating, and due to which we do land up doing perhaps less numbers of sinus elevations when it comes to doing a more invasive procedure. So let's look at something which is less invasive now. Let's look at some more minimally invasive options. And then you're looking at the crestal approach, also known as the indirect sinus lift, or the Summers technique, or the osteotome-mediated sinus floor elevation. The two problems that we face when it comes to doing the crestal approach, because it's a blind approach, you don't have direct access to the sinus or the Schneiderian membrane. What we have experienced in the past, and what is again backed by literature, is the number of membrane perforations. So some studies have put it as high as nearly 40% of membrane perforations with the crestal approach. And the other technical difficulty as clinicians for us has always been to place large amount of graft materials through a small opening over there in order to achieve a substantial amount of lift. So traditionally we've been using particulate materials and pushing small amounts of those materials with osteotomes or other tools, and we've realized that there is a limit to which we can actually achieve a vertical increase in height. So maybe about 2 to 3 millimeters or maybe 4 millimeters at the most is what we are looking in terms of gain in height using the crestal approach. So if we were to have a wish list over here for all of us, as far as the crestal approach is concerned, as clinicians, I would like a crestal procedure with minimal amount of perforations and ease of placing grafts. So as a clinician, these are the two features that I would really like when I'm doing a crestal approach. When it comes to the patients, all patients would love reduced surgical trauma, minimum complications, extremely fast recovery. And when it comes to educators, this is what we would like. We would like procedures which are simple, which can be easily taught, and more importantly, are procedures which not just can be done by the teacher, but very easily can be done by the people who we are sharing this knowledge with. So we want procedures which are easily reproducible, and we are always in the search for procedures in whatever form of implant dentistry that we are doing, trying to search for procedures which are less invasive, comfortable for the patients, easy to teach, and more importantly, reproducible. Coming to all the innovations that have happened over the last few years, and you see, as we speak, there is something new happening in this field of sinus elevations, and the number of innovations, the number of new techniques, the number of new tools that have been developed have been quite mind-boggling in the last 5 to 10 years. So if we really had to classify the innovations that have occurred, we could actually put them in 3 different categories. So you have some tools that have been innovated for breaching the sinus floor atraumatically without tearing the Schneiderian membrane. Then you have certain innovations which help us to lift the membrane again atraumatically without causing any perforation. And the third is some method in which you can easily introduce the graft. So if we were to really categorize it, it would all pretty much fall into these 3 categories for ease of surgery. Let's look at the first one. When it comes to breaching the sinus floor, the osteotome technique has been one of the oldest one to breach the sinus floor and introduce the graft material. As the years have rolled by, we have seen some really nice innovative crestal drills which have really changed the way we had done sinus lifts in the last few years. Minimal amount of perforations, minimal amount of post-operative complications. Again, the piezo surgery is extremely atraumatic, extremely predictable to go through the floor of the sinus without really tearing the Schneiderian membrane. And the last one, of course, the revolution that is taking place these days is the Densa drills to be used for doing your sinus elevation procedures. The innovations in lifting the membrane, we have seen the balloon lifts about a decade ago, which became extremely popular. And you also have a lot of these kits which help us to use hydraulic pressure to lift the membrane up without causing it. So a lot of these kits and a lot of these new advances have been developed to lift this lining so that we can introduce the graft material in. An interesting article here talks about the mechanical properties of Schneiderian membrane. It also gives us a little description of how tenacious the Schneiderian membrane can be and at what threshold it can rupture. So this also gives us good information about how the sinus morphology, how the shape of the sinus will help us in identify which cases are more suitable for a crestal approach and which might be better off for a lateral approach. So again, an interesting article to refer to. The third and the most important one is introducing the membrane, introducing the graft. So at times we have managed to breach, we have managed to elevate, but the bigger difficulty is to introduce a substantial amount of graft material which can keep the membrane up over there and maintain the space. And in that we've been pretty much using these traditional methods, these bone carriers, amalgam carrier like instruments, and using particulate bones in small increments and trying to push it up. But what has again really changed the way we have been practicing in the last few years is this innovation in a delivery system for delivering the graft material. I don't know how many of you are exposed to this, but this is a product called Novabone. This is an alloplast material. It is biphasic composite graft, and it is available in a delivery system which looks like this. So you have this little disposable cartridges with the graft material inside, which is in a putty consistency, and you have a delivery system which is like our composite syringes, and very convenient to inject material into the surgical sites. So I'm going to talk a little bit more about this particular material. We've been using this for the last 6 to 7 years in our country, and we started off using it more for our lateral window elevations, lifts. We conducted a few biopsies, studies out of that, and to test whether the material really is turning around. And something that we presented at one of the ITI meetings, a case series of 4 such cases where we were able to take some biopsies of this to see what kind of bone remodeling takes place. And while we were at it, we also stumbled upon something very interesting, is that the cannula of the delivery system coincides exactly with the 3 millimeter osteotome. So about this must be about 6 years ago when we started using this material. We realized that we can make use of this, this combination of a 3 millimeter osteotome and using the Novabone cartridge. And we came up with one specific technique of doing this procedure. We called it the minimally invasive transcrestal sinus augmentation. So this was the protocol. What we would do is we would start off with our pilot drill and stop about a millimeter short of the floor. The next step was to widen the osteotomy to the final drill, again keeping it about a millimeter short of the floor. So until now we have not really breached the floor. The third step would be to use the 3 millimeter osteotome. So this osteotome is the real key to the success of the treatment. And just a few gentle taps over there would help us to fracture the floor of the sinus. After which we would take the cartridge and introduce it inside the osteotomy. And the nice thing about it is because of the coinciding diameters, the 3 millimeter osteotome would, the 3 millimeter cartridge would fit exactly in the region of the osteotome. And once we injected the material itself helped in elevating the sinus. So here now we were making use of the hydraulic pressure, the viscous nature of the putty itself to lift the sinus up, at the same time deposit the material. So what we achieved in this is not just lifting the sinus atraumatically with minimal perforations, but also depositing the amount of graft material over there and then ending up the case by just placing an implant. So we got very excited with this when we saw some of our cases where we were able to achieve a substantial amount of lifts using this combination. So I'll just talk you through this one case where we had to do sinus elevations with grafting for two sites over there, the two molar sites. This is the protocol. We start off, like I said, with the starter drill. We go on and widen it gradually to the final drill, keeping it about a millimeter short. This is the same thing done for the second site. So those are the osteotomies that were made. After that, we pick up the 3 millimeter osteotome and insert it inside and take it all the way down up to the floor of the sinus. A few gentle taps onto the osteotome is enough to just fracture the floor. Once that's done, we take the cartridge, take the cannula all the way up to the floor into this position, and then inject about half cc of material. So each cartridge is about half a cc of graft material. Once we inject that, we go on to the second site and we use the osteotome in the second surgical site. And meanwhile, you can see the amount of elevation that takes place with the hydrostatic pressure there. We repeat the process on the second site. We use another half cc of material over there, and following that we go ahead and place our two implants. This is your radiograph immediately post-operatively. That's the kind of lift that you get to see. I know it's a little excessive, you don't really require that kind of lift, but that's the amount of lift that can occur with just 1 cc of material. And what's really nice about it is the circumferential lift that you get. It's not just in one dimension, it just seems to spread very, very nicely all around. So as the implant goes up, you start seeing that the graft material is also nicely getting distributed circumferentially. So cases like this got us really excited. We were able to go ahead and plan cases, do more and more of these type of surgical procedures. We decided to publish this. We published about a case series of 20 cases done using exactly the same technique. We also did a presentation at one of the European Academy of Osseointegration symposiums where we did an oral presentation in the clinical research session. And we had a study designed for that where we were comparing the results of lateral versus the crestal approach using the same graft material. So the objective over here was to try and see if we can take away some cases which were typically indicated for the lateral window approach, and see if we can take those cases and use a crestal and a more minimally invasive approach in doing the sinus elevation procedures. So this was our study design. We had about 40 patients. We took 20 patients in each group. We used the same material in both. We standardized the material. We used the same calcium phosphosilicate putty. We loaded all those cases in about 6 to 9 months, and we wanted to study the clinical success and the radiographical evaluation of increase in height of bone. We standardized our radiographic methods. We also standardized the material, so we use the same material, the putty, and standardized the implants, implant lens too. We used all the implants of 10.5 millimeter lens. These were our results out of the 40 patients that we treated. we had initial pre-treatment bone levels were all less than 5 millimeters. So they were all in the 3 to 5 millimeter spectrum. So the average was around 4.2 in this group and about 4 in the other group. The post-treatment heights were quite encouraging. We could get as much as about 10 millimeters of lifts in almost all the cases that we did, even using the crestal approach. So the mean sinus gain was almost up to 10 millimeters using this technique. We had implant survival rates also, which were quite similar. We lost one implant to osseointegration in both the groups. So in the end, we could conclude that there was really statistically not much of a difference in terms of at least implant survival and in terms of increasing the height of bone. So the advantages here, you're looking at a more minimally invasive approach, you're looking at ease of graft placement, you're looking at less sinus perforations thanks to the putty consistency of the material, less surgical morbidity, and something that patients find it very, very appealing. And of course, for a country like ours, where you see that majority of the population really cannot afford expensive surgical treatment, a lower cost of the treatment also is a huge, huge benefit. Nevertheless, the membrane perforations would still continue to be a bit of a problem, especially in untrained hands, where you still have a high percentage of perforation, especially using the osteotome technique. So that was a time when we had to start using better tools, safer tools, where we were able to maintain the Schneiderian membrane without perforation. We started doing sinus elevation using some of these crestal drills, which I think were again a great innovation in trying to maintain the integrity of the membrane. So this is again an example. We followed the same technique. Instead of using the osteotome, we moved on to these crestal drills. That's how the site is prepared, and that's how the material is injected. In the end, this is how the case ended up. This is how it looks after the bone remodels. And what I really like over here is that immediately after you see the post-operative radiograph, you see a nice, good radiopaque, dense material over there, which is tenting the sinus membrane. And as you load it, and by the time you see that there's bone remodeling over there, it almost starts looking like the trabecular pattern in the native bone. Then, of course, it was time for a revolution, and in the last couple of years, this is what has completely changed the way we are doing procedures. That's the osteodensification, and thanks to this remarkable gentleman, Salah, who has really, really changed the way we are preparing our implant sites these days. So we decided that we could start doing sinus lift procedures with this, and again following the protocol that somebody like Salah and Dr. Ziv Mazor has so well explained to us. We are able to take even cases like this with a massive amount of resorption. We are looking at cases which have a starting point of around 3 millimeters of bone to start with, and instead of the more invasive lateral approach, we are looking at doing these cases following the classical Densa protocol, where the drills are used in a reverse direction at a specific speed. We are able to take these cases, prepare the sites, breach the sinus floor, using sequentially widening drills, at the same time making sure that because of the atraumatic nature of the drill end, we are not perforating or damaging the Schneiderian membrane. So that's just an example of how the lining can remain intact over there after using the Densa drills. Following this, we are using the same material again. The putty goes in. That's where we go and deposit the putty. Use the drill again at a much lower speed now. You go in at about 150 and use the drill in a reverse direction to propel the material inwards. Go ahead and place the implant, and at the end of it, this is what we are achieving. Again, you see this nice, good radiopaque material surrounding the apical part of the implant, which again gives us an indication of the immediate success of the treatment as soon as you finish. Let me go through a couple of these videos for you. This is what we were doing previously, the osteotome technique, and these days with the Densa drills. And you'll see that the Densa drill is also acting like an osteotome over here, just that it's far more comfortable for the patient, less traumatic, and highly predictable. So the video here on the left is the previous technique using the osteotome. We were using the conventional drills that we were used for our implant site preparation. We keep it about 1 millimeter short. And what you see on the other side over there are the Densa drills, which are being used in the counterclockwise direction in the densifying mode, where you are not only creating an autograft there, but you're also able to breach the sinus floor quite effectively without perforating. So again, as you see, there is a sequential increase in the diameter of the osteotomy. And of course, take some radiographs over there to verify that you are right there. Now you see over here on the left side is just a few taps with the 3 millimeter osteotome, and that's enough to fracture the floor, following which we will now be injecting the nova bone. The video there on the right, the sequential increase in diameter. The same material, the same quantity of material goes in. So that's the bone graft material that's getting injected, which is creating the lift. And what you see on the other side, again, the denser drills being used. So that's the putty again being injected inside. The last step is to place the implant, and the implant will again drive the graft material further apically, increasing the amount of lift that you will achieve. And these are the immediate post-operative radiographs of both the techniques. So whether it's the osteotome, which is the older technique, or the densa that we are doing now, which is the newer technique, pretty much comparable results there. What we've also started doing is using denser drills again for ridge expansion. So you're looking at not just using it for sinus elevation procedures, but also looking at cases like this where we have deficient ridge in the horizontal dimension. And if you were to really break down these into three and see that we have about 4 to 5 millimeters, 3 to 4, and 2 to 3, and then choose a surgical approach based on the amount of available bone over here, you're looking at about 4 to 5 millimeters, which we could easily manage previously with an implant placement and a guided bone regeneration. The second category where we would typically be doing a ridge split procedure and place an implant over there in the center with a good amount of bone on either side. And the third option where you have barely enough bone for implant placement, we are looking at staged approach of placing a block graft or maybe the titanium meshes and building up the entire alveolus for implant placement. But what we are doing now, especially in the category which is between 3 millimeters to about 5 millimeters of bone, is instead of removing the bone, we are just moving it using these drills again in the counterclockwise motion. So what we are again achieving is a significant amount of expansion of the ridge apart from densifying the bone and getting much higher ISQ values at the time of implant placement. Let me show you this last case of my presentation where we actually push the envelope, where we are looking at a situation where we have a deficient amount of bone in the height as well as buccolingually. So you look at this situation where there is a minimal amount of bone over there. We open up the site and we start off the same protocol. We start off with the 2 millimeter drill right up to the floor of the sinus, and then we use a 3 millimeter drill in the counterclockwise motion to breach the sinus floor. Following that, again, we use the nova bone, the cartridge goes all the way in, we inject the material. After that, the implant has been placed, following which, because that's the kind of ISQ values that we get even in deficient bone situations like this. We usually land up doing a veneer graft over this, using a graft material of your choice, a membrane, and close it up. That's how a case like this can be ended up. Again, immediate post-operative view with a classical radio-opaque opacity around the apical end of the implant, and then the remodeling that takes place about 6 months down the line after we load the crown. So we started off discussing the spectrum of cases between 4 to 7 millimeters as our classical crestal approach lift. But what we've been really achieving in the last few years is broadening that spectrum, really getting the crestal approach and increasing the scope of that and coming to almost like a 2.5, 3 millimeters of available bone, where we are able to get just enough bone for our implant stability and managing to do the sinus elevation procedures with the crestal approach. So to conclude, all these innovations in tools and biomaterials have expanded the scope of crestal sinus elevations, making them more predictable, minimally invasive, and more importantly, very, very reproducible. So with that, I really thank all of you for being a wonderful audience. Again, my gratitude to Eddie and Morris. And again, an open invitation for all of you who ever come to visit my country. If you ever land up being in Mumbai, be prepared to face that kind of crowd. And if you really need some help over there, you know who to contact over here. That's my email ID. Don't hesitate to get in touch with me. Thank you very much. And before we go, this is one thing that I wanted to share with you. Unfortunately, our next speaker of the day is not going to be with us because of her flight being cancelled. But yeah, we all miss you, Snezana, and this is just something that we're really going to miss her. And I hope that somebody takes a picture of this and sends it to her. So thank you very much again. And